My name is Debika Bhattacharya, and I'm an infectious diseases physician at the University of California, Los Angeles, where I study novel treatments for hepatitis B infection. And I'm honored to be able to talk to you today about immune checkpoint inhibitors in the treatment of hepatitis B. Here are my disclosures. So what are immune checkpoints and inhibitors? Well, there are two main types of immune checkpoint inhibitors that are being used in cancer immunotherapy now, and they are CTLA4 and PDL and PD1 inhibitors. So what is the mechanism of action? The mechanism of action is that these immune checkpoint inhibitors essentially reverse immune exhaustion. So here on this pictorial, on the left-hand side, you can see how CTLA4 and how PD1 and PDL1 work here. The first part of the slide is an antigen-presenting cell, and the second part of the slide is the tumor cell. And so these immune checkpoints, CTLA4, PD1, PDL1, they are produced naturally and are a way for the immune system to downregulate the immune response, particularly the T cell response, so that there is not an overreactive immune system. And so what cancer cells do, and some viral infections do, is they take advantage of this naturally occurring mechanism, and they bind these molecules, these immune checkpoint inhibitors. So here on the left-hand side, with the antigen-presenting cell binding the CTLA4, and they go ahead and they inactivate the T cell. The same is true here for a tumor cell and PD1 and PDL1. PDL1 stands for the ligand of PD1. And what the new antibodies, the checkpoint inhibitors, so an antibody against CTLA4, an antibody against PD1, or an antibody against the PDL1, the ligand to PD1, do is they compete, and they instead block this interaction. And as a result, they take the brakes off of that downregulation and they reactivate the T cell. And that's seen here in yellow on both sides. And this reactivation or reversing of immune exhaustion is what has revolutionized the field of immunotherapy. And over the last decade, there have been several FDA-approved agents, starting in 2011 with ipilimumab, which is a CTLA4 checkpoint inhibitor, to most recently dostarlimab for PD1. And of course, I think perhaps the most famous that we're seeing is the responses in metastatic melanoma, where in some patients, the responses have been really quite amazing, putting folks into remission. So what about other applications for immune checkpoint inhibitors? As I've kind of alluded to already, immune exhaustion is a cardinal finding for some chronic viral infections, including chronic HIV and hepatitis B. In HIV, there has been an in vitro study demonstrating that anti-PD1 treatment may in fact reverse HIV latency. Well, then what about hepatitis B? And I think it's first important to start by recognizing why we are focusing on hepatitis B. One is it's important to remember the global burden of disease. When you think about hepatitis B compared to HIV, for example, the estimated global prevalence of hepatitis B, now this is 2015 data, is almost 260 million people with hepatitis B surface antigenemia, or with chronic hepatitis B infection. And this includes about 115 in the Western Pacific, about 40 million in Southeast Asia, and 60 million in Africa. So a huge global burden of disease. And so why then would we want to use immune checkpoint inhibitors in hepatitis B? Many people ask, well, antiviral therapies already exist for hepatitis B, and they result in long-term HBV suppression. But the reality is, although they result in long-term HBV suppression, they do not result in functional cure, just like long-term HIV suppression does not result in HIV cure. And the inability to attain HBV cure is related to two main things, we think. One is the inability to clear the reservoir of hepatitis B in the hepatocyte, and that is through the establishment of a latent reservoir called cccDNA, or covalently closed circular DNA, and also T cell exhaustion. So here I want to show you, I want to kind of highlight both the establishment of the latent reservoir in hepatitis B and also the importance of immune exhaustion. So this is a very complicated diagram here on the left-hand side of the hepatitis B life cycle. But what I want you to pay attention to here is the entry of the hepatitis B virus into the cell comes into the nucleus here. And it establishes a latent reservoir here, as we've called already, cccDNA, or covalent closed circular DNA. And this serves as the latent reservoir. And because drugs do not work on this part of the reservoir, you cannot functionally eradicate hepatitis B yet. The other important thing to note is that because in part of this reservoir, there is production of the mature HBV virion, but there is also production of these surface antigen subviral particles. And this production of antigens then takes us to the immune side, where this excess production of antigen, often hundreds to thousand-fold in relationship to the actual virions, this production of excess antigen contributes to immune exhaustion. And current HBV therapies work on eliminating viral load production, which definitely decreases some of the surface antigen or some of these antigens that cause immune exhaustion. But because of the latent reservoir here and a parallel pathway where they are able to independently produce these surface antigen subviral particles, it does not, antiviral therapy does not effectively eliminate all of the byproducts of hepatitis B virus production, and that also contributes to immune exhaustion. And then another rationale for the use of immune checkpoint inhibitors in hepatitis B is the development of checkpoint inhibitors against particularly PD-1 and PD-L1 have reversed T cell exhaustion and restored anti-tumor immunity, obviously in cancer immunotherapy. And I think very importantly, PD-1 and PD-L1 in particular as an immune checkpoint inhibitor is relevant in hepatitis B. And so what you see here is a paper that demonstrates the relative frequencies of differential production of different molecules, including PD-1 and CTLA-4 in hepatocytes. And as you can see here, PD-1 is the most relevant checkpoint inhibitor for hepatitis B, expressed in the most quantity. It's also expressed on HBV-specific T cells, and the ligand for PD-1, PD-L1, is present on liver cells during active inflammation or hepatitis. And so, as a result of of the rationale that's presented, there has already been a proof of concept study of the use of a PD-1 inhibitor, nivolumab, in chronic hepatitis B infection. In this particular study, which looked at approximately 24 patients with hepatitis B who were given one dose of an immune checkpoint inhibitor, nivolumab. In this study, one participant was able to achieve functional cure, which is characterized as the loss of hepatitis B surface antigen. And also, this person was able to stop antiviral therapy, tenofovir, 4 weeks after dosing, and has remained off of antiviral therapy, remaining surface antigen negative, and has gained the antibody to hepatitis B surface antigen, and the viral load is undetectable. And so this was really an interesting proof of concept. Of course, the one thing that we did see here highlighted in the pink is an elevation in the ALT during this time, coincident with the decrease in the levels of hepatitis B surface antigen. And we think that this was what we call a beneficial immune transaminitis flare, as a result of immune restitution to hepatitis B. So that brings us to a study that we are also designing within the AIDS clinical trials group. This is the CHECK HBV study, A5368, where we are going to be looking at a monoclonal antibody, cemiplimab, also recently FDA approved, to see if it will be safe and well tolerated in HBV infected participants on suppressive antiviral therapy. And where the nivolumab study looked at one dose, we'll be looking at two doses spread out over 6 weeks at three different dosing cohorts with 10 participants each. So this is a multiple dose ascending study. And we will be evaluating safety after each cohort completes its safety at week 18. And we'll also be looking at liver biopsies and fine needle aspirates for all participants before and after therapy so that we can really look at the intrahepatic cccDNA, the CTL responses, and cell type specific gene expression changes, which are going to be very important from a translational science standpoint. And we'll be enrolling 30 individuals in this study. The primary objective is to assess the safety and tolerability of multiple dose levels, but we'll also be evaluating virologic and immunologic, including intrahepatic markers, PK, and receptor occupancy responses. We really anticipate this is a highly anticipated study in terms of how PD-1 therapy is expected to impact hepatitis B infected patients. And where we think this will lead us is to be, if this is proven to be safe and has efficacy, this will likely be a part of a combination therapy. So looking forward, we think that hepatitis B therapy is going to need to have multi-mechanistic approach, which will involve HBV DNA suppression with the currently available nucleoside or nucleotide analogs, viral depletion. There are currently different ways that these are being investigated, including RNA silencing, nucleic acid polymers, and also cccDNA inhibitors, and then leveraging the immune system. And anti-PD-1 or PD-L1 might be one of those approaches, perhaps coupled with a therapeutic vaccine or coupled with a TLR7 or 8 agonist. But what about side effects? So one of the side effects of immune checkpoint inhibitors as a whole are immune-related adverse events. And they really run the gamut of all organ systems. These are off-target effects. And with the most common, I think, for PD-1 in particular, being endocrine effects. And so when we start thinking about, so in particular, those with HIV and hepatitis B co-infection or hepatitis B and C monoinfection, I think it's important to review the safety of these immune checkpoint inhibitors in those participants. And so this was one systematic review that was published in 2019 that looked at individuals with HIV and advanced stage cancer who received immune checkpoint inhibitors. It was 73 patients. 85% were on anti-PD-1 therapy, whereas 6% had combination therapy with CTLA-4 and anti-PD-1 therapy. And they found that the frequency of grade 3 immune-related AEs, grade 3 or greater immune-related AEs, was 9%. And of those, 67% were receiving ipilimumab. And looking specifically at those with viral hepatitis, looking at those with Hep C and Hep B, there was actually no change in LFTs in those who were receiving immune checkpoint inhibitors. Interestingly, among those with undetectable HIV viral loads, about 7% had an increase in HIV viremia, and there was also an increase. There was also either an increase or a decrease in CD4 counts. I think it's important to remember that as we think about studying immune checkpoint inhibitors in hepatitis B, we're only going to be studying very finite durations, 1 or 2 doses of these immune checkpoint inhibitors, rather than what is normally done in cancer therapy, which is high doses of immune checkpoint inhibitors given every 2 or 3 weeks for often months to years. And so the anticipation is that the side effect profile will be markedly better with just 1 or 2 doses at smaller dose amounts. And then finally, I think it's important to think about drug-drug interactions. And here, it's a really interesting way to think about drug-drug interactions with immune checkpoint inhibitors, because you have to think about immune system mediation as well as gut microbiota. And so when we talk about immune mediation, it makes sense that a mechanism of action that works by reversing T cell exhaustion might also be impacted by those things that impact the immune system. And so, one of the drug drug interactions that are hypothetically linked to alterations or to impact outcomes with immune checkpoint inhibitors are steroids. So, some studies show worse outcomes with malignancy outcomes with the co administration of steroids. Similarly, there's a concern about vaccines. Could they increase the risk of immune related AEs? Some thought leaders recommend that patients receiving CTLA-4 inhibitors, in particular, wait 68 weeks after immune checkpoint inhibitors. And then finally, hypothetically, again, proton pump inhibitors may alter the expression of adhesion molecules and or alter secretion of pro-inflammatory cytokines. And that may also impact responses. On the other side, there is the gut microbiota, which I think has had a surprising relevance in the field of immunotherapy. So, in fact, gut microbiota composition and its heterogeneity provides immune protection and can impact ICI outcomes. So, certain gut flora, for example, are beneficial and are present more in patients with a response from a chemotherapy, from an oncology standpoint, with immune checkpoint inhibitors. Antibiotics and proton pump inhibitors do alter gut microbiota. And one of the hypotheses is that antibiotics may decrease the diversity of gut microbiota, reducing the overall beneficial immunogenic bacteria. And in fact, antimicrobial therapy has been demonstrated to have a negative impact on outcomes with the use of immune checkpoint inhibitors, with overall response rate, progression-free survival, and overall survival. There is also a hypothetical concern with proton pump inhibitors for the same reasons that we talked about in terms of impacting gut microbiota, but these have had conflicting results in clinical trials. So, in summary, immune checkpoint inhibitors have revolutionized the field of oncology. The mechanism of action suggests that it may be useful in other diseases with T cell exhaustion, including hepatitis B. And that was also demonstrated, at least in one participant, in a proof of concept study with nivolumab. And immune checkpoint inhibitors, rather, may play a role in combination treatment strategy for hepatitis B. In fact, it's really being looked at by a lot of companies that are developing novel therapeutics for hepatitis B. However, it's going to be important to look at immune-related adverse events and its drug-drug interactions, and these will be important to monitor in this developing field. So with that, I'll end, and thank you for your attention.